Giving a good AV. So today I am going to speak a few things on the neuro interventions in acute ischemic stroke. So as we all know, till now everyone is aware about the management, as we all are stroke treating physicians. We all are aware regarding the management of acute ischemic stroke beyond the window period and during the window period with an intravenous thrombolysis either with alteplase and tenecteplase. So now, as we all know, in the last few years, the management of stroke has undergone a rapid changes in its management to improve the outcomes in the patient. As we all know, the stroke is the second most common cause of death in India, and about 1,85,000 stroke occurs in every year in India, with nearly one stroke every 40 seconds and one stroke death every 4 minutes. And these studies from All India Institute of Medical Sciences, New Delhi. To come to the stroke pathophysiology, as we all know, there is an arterial occlusion. There are lots of cascade of events that happen in the brain, finally leading to the cell death. So as we know, this mechanical thrombectomy is an endovascular technique. It is a technique that removes the clots from the brain and which restores the blood to the brain. So this is a simple approach to identify the acute ischemic stroke. It is a B fast approach. B for the balance, any loss of balance, either in the form whether a patient is swaying to either side while walking, or vision changes, eyesight changes in the form where a patient gets sudden blurring of vision or is not seeing one side of his vision, that is hemianopia, and facial, F stand for the facial drooping, arm weakness, speech difficulty, and T is the time to act. So this is the simple mnemonic or infographic to identify the stroke rapidly. So now, how to manage a stroke in case of a resource limited area with a simple CT scan? Whenever we identify the patients with acute ischemic stroke, we get a non-contrast CT, and the symptom onset is 0 to 4.5 hours, or within 4.5 hours we will determine whether this patient is eligible for IV thrombolysis. Then we administer IV thrombolysis. We go for immediately, if we identify the large NIHSS big stroke, we go for a CT angio, then we go for endovascular thrombectomy. Now the patient is gone beyond the 4.5 hours, we take for a CT angio, we have a clinical imaging, there is no clinical imaging mismatch, and there is a large vessel occlusion. When if any salvageable tissue is present, we go for mechanical thrombectomy. And now someone is asking about the door to needle time. Whenever a patient arrives to your emergency, there should be less than 10 minutes an initial evaluation regarding the history, lab workup, and NIHS assessment. Less than 15 minutes, we will just notify to the team. Whenever a stroke comes, we will notify that in our hospital, whenever any stroke within the window or up to 12 hours comes, that emergency physician will assess him. We will give information to the neurophysician, neurosurgeon, radiologist, and CT technician, and the information goes to the cath lab. So whenever we identify the patient, we take a CT angio, or MR angio, depend upon the time of the presentation. And we also have a rapid sequence diffusion, which takes less than 50 seconds to identify to finish the diffusion sequence, and we counsel the patient, whereas our MODs and financial counselors and our stroke educators and our nursing team, they will counsel about the consequences and benefits and complications of IV thrombolysis and mechanical thrombectomy. And once we are ready, we will administer that agent. And in the angiogram, if there is a large vessel occlusion, and depend upon the time of presentation, we will take the patient either for mechanical thrombectomy or we give IV thrombolysis and manage the patient. So the ideal door to needle time is for the alteplase is less than 60 minutes, whereas in mechanical thrombectomy, if it happens in the center, it's 60 minutes. When we follow the drip and ship model, we allow up to 90 minutes. So till now I have been speaking about NIHSS. Now what is this NIHSS? Is a National Institute of Health Stroke Scale. So it's a 11-item scoring system, measures stroke related neurodeficits. This includes testing of loss of consciousness, selected cranial nerves, motor, sensory, and cerebellar system. The maximum score is 42 and minimum score is 0. Now we see, this is a 11-point item score which I want to emphasize on this slide, where we assess the level of consciousness, response, that is orientation, response to two commands, gaze preference, whether the normal eye movements or partial gaze palsy to one side but forced gaze palsy to the one side, and visual fields, facial motor function, assessment of power both upper extremity and lower extremity, any presence of ataxia, sensory function, language, extinction or inattention which is seen in cortical strokes. So for the rapid assessment, it is very tough to remember all those things, as practice will teach us everything. Now ready-made mobile softwares are available, MD Calculate. Just examine the patient, put the point, it will give you the score. It is MD Calculate NH app is available, or we will keep a stroke bundle. Whenever a patient comes, that onset, last seen well, comorbidities, medications such as most of them will have comorbidities such as valvular heart disease, whether the patient is on any anticoagulants, and we assess the CT image form and then NHS form, indications and contraindications for IV thrombolysis, consent form, then we go for IVD. It's a bundle of 5 papers we just made in our hospital. Now this NHS, what does it do really? It assesses the stroke severity. More the high score, the probability of large vessel occlusion is more. Suppose if NHS is 0 to 4, it's a minor stroke. Why this is important? Some take up to 0 to 6 and some studies take up to 0 to 5. So if NHS is less than 5, it's better to wait for IVT or intervention because it is a minor stroke. And many studies have offered IV thrombolysis and mechanical thrombectomy in low NHS scores, but the complication, the benefit is less compared to the damage to the patient. So 5 to 15, if NHS is more than 5 to 6, yes, we can offer intervention, and 16 to 20 it's moderate to severe stroke, and about 21 to 42 is a severe stroke. So now coming to that imaging in acute ischemic stroke, that is CT brain, CT angio, MRI brain with MR angio, we can aspect CT aspects or MR aspects, and CT and MR perfusion, which is hardly available in 1 or 2 centers in India. So if we see any patient has come to the stroke, suppose an hypothetical scenario was given by our sir, that any patient with 58-year-old lady with right upper limb and lower limb weakness and speech distribution. So we have taken a CT. So what is our first concern? Yes, there is no bleed, but what other signs are there is much more important. If we can, am I audible to everyone, clear till now? Or, so you can see this white color thing which is not seen here. This is called hyperdense sign, hyperdense MCA sign, which indicates that MCA is occluded and the thrombus present inside the blood vessels appears as hyperdense on CT. Coming to the here, if we see in this side, you can see the white and black color, whereas here we are not able to see the white and black color, and this is called loss of gray white matter differentiation, which is a soft sign that we can pick up on CT. And now I also mentioned the aspect score, that is Alberta stroke program for early CT score, which gives the 10 involved areas, particularly in the MCA levels, one at the ganglionic level, other at the supraganglionic level. You can see the caudate nucleus, internal capsule, lentiform nucleus, M1, M2, M3, other is the posterior limb of internal capsule, M4, M5, M6. To the area involved, we will give 1 point each. On a score of 10, we will reduce 1 point. So it is used for MCA territory. Now it has been extended to the posterior circulation territory also. So this any aspects more than 6 have good outcome for both IVT and mechanical thrombectomy. So what are the limitations? As I mentioned, most of the people have the small vessel disease and motion artifacts, because most of the stroke patients will be in altered sensorium, moving their head and irritable kind of thing. One of the thing is important to have when we are going for intervention, the knowledge of a cerebral vasculature. As we all know, coming to the anterior circulation, from the ICA it gives the anterior communicating artery and the middle cerebral artery, and this anterior cerebral artery communicates the other via communicating, and 2 vertebrals form the basilar and PCA, and this is the posterior communicating artery. And this on typical MR angiogram film, this is much more important. Can someone volunteer to the vessels? Anyone can? So what is this vessel? Yes, it's an ICA. If we trace this ICA, it is bifurcated into anterior cerebral artery, middle cerebral artery. We can see the superior division and inferior division, and the 2 vertebral arteries, basilar artery, PCS, and this comes to the pica arteries, and the same on the opposite side. So why this is important? Because we have to define what is a large vessel occlusion. So this basilar artery, ICA terminus, M1, the superior divisions are called a large vessel occlusions. Beyond that, sir? So beyond that we call it as a medium vessel occlusion. Recently now mechanical thrombectomies have been offered for this medium vessel occlusion also, but it is only limited to very few centers in India. So why a mechanical thrombectomy in large vessel occlusion when we have an IV thrombolytic agent? Yes, these large vessel occlusions are very less responsive to IV thrombolysis, that is they have lower recanalization rates with TPA, and they recanalize at only 1/3 of success rate for IV thrombolysis. Coming to the natural history, when there is a large vessel occlusion, when there is no revascularization, the neuronal death happens and 64% of the patients become either dead or dependent at 6 months. When offered timely intervention, there is a significant reduced disability up to 90 days, and the number needed to treat is only 2.6. Coming to the natural history of how this mechanical thrombectomy has evolved and overcome the myths is, till 2013 and 14, most of the recanalization procedures were very less successful. So after the 2015, the first positive wave of trials have occurred up to 12 hours from the last known well, that is an extend IA Mr. Clean Swift Prime Revasc Escape. They have given a good outcome for all these mechanical thrombectomies. Now coming to the 2022 and 2023, as I already mentioned, our mechanical thrombectomy trials have also been done for the lower aspect score. So EVT within 6 hours, these trials showed benefit of mechanical thrombectomy within 6 hours in patients with large vessel occlusion in anterior circulation. So what is our goal of recanalization? Just like TIMI flow, we have a TICI flow, either 2B to 3, either complete filling or complete perfusion. So these are all trials that have a good 90-day functional outcome, improved MRS scores and less hemorrhagic transformation. Now coming to expanding the window beyond 6 hours up to 24 hours, we have two trials, Dawn and Diffuse. So this Dawn and Diffuse, the Diffuse is 6 to 16 hours since the time known well, IC or M1 occlusion. It requires a perfusion imaging, whereas the Dawn trial is a clinical imaging mismatch. So it's up to 6 to 24 hours. Outcomes, disrupted the time. These trials have disrupted the time window concept in acute ischemic stroke, showing good clinical outcomes in patient treated up to 24 hours from onset, and effectiveness of late window thrombectomy has maintained across all subgroups, and the safety profile has also been demonstrated. Now what are the indications for mechanical thrombectomy? Acute ischemic stroke with large vessel occlusion, NIHS more than 6, CT aspects more than 6, pre-stroke MRS. It is a modified Rankin scale is less than 1, which calculates the disability, and Dawn and Diffuse selected patients up to 24 hours, but however in our center we are giving only up to 12 hours because we don't have any perfusion imagings. Now the other medical techniques, these mechanical techniques are adapt techniques. What adapt we do is we just only aspirate the clot, other is with a stent retriever, Saltair, and other is Solumbra, we aspirate and go a stent retriever. So these are the devices for mechanical thrombectomy, penumbra system. And now this is a case where we have done in Medicor hospitals. So here is a 54-year-old male, diabetic and hypertension, ischemic heart disease, post PTCA on double antiplatelet therapy. His last seen normal at 3 p.m. He went to sleep. At around 7 p.m. when he woke up, he was not getting up, and the family members found him to be drowsy with decreased responsiveness. So immediate MR angio was done. You can see any abnormality can we identify in this thing? There is no basilar artery here right now. There is no basilar artery. We see this MR imaging that we got from we didn't wait for the report. We asked the technician to send that MR, and this MR has been done. You can see the total pons and PCA territory has been involved, right? So we have around 9 p.m. he came to the Medicor hospital. On examination, he was in locked-in state, quadriparetic, and only making few incomprehensible sounds to pain. So we were taken to the cath lab. So we have done a DSA which showed the proximal basilar occlusion. So we have done only aspiration, which got the complete recanalization of these vessels. We can see the basilar artery, PCS. Only partially we cannot recanalize because the clot is also distal, its ICAD is there. But however, the entire brain is getting perfused. So the next day he became conscious and oriented. He is obeying all commands. There is dysarthria. The power in all limbs were around 4/5 improved. So at day 3 he walked independently with support, and within the next week he resumed his government job. So this is a case 2 where is a 35-year-old male with aphasia, right hemiplegia and right UMN facial weakness. The NHS is around 14. So this is the image showing. You can see that someone can identify the abnormality here. I think we'll play it again. So you can see the left M1 is totally blocked here. You see, as I shown in the normal angiogram, beyond this M1 there is no visibility of M1 superior division and inferior division. So that we did only contact aspiration for this patient, and you can see the recalculation of the vessels. So other cases, so now this is a patient with recurrent stroke, how we managed it. This is a 68-year-old male. He had right MCA territory infarct 10 days ago. He had, as routine, we do a carotid Dopplers, whereas right side is showing 85% stenosis and left side is showing 80% stenosis, and the patient is already on DAPT and recently he was shifted to ecospirin and ticagrelor, and he was on high dose rosuvastatin. So we have taken a DSA here where you can see severe stenosis of ICA there. See the long segment stenosis of ICA about 85%. So what we did is, this is the materials we have used with a femoral puncture, word diagnostic catheter and lengthwise. And one point I want to stress is an embolic protection device. So there is a myth that whenever we do a carotid stenting, the chance of stroke is high. So we deploy an embolic protection system just like an IVC filter. We keep this in the ICA. We do angioplasty and stenting, and after that we make sure the stent has been done. There is no, then we will remove this filter and take a shoe. Now these are the exact system, and this is an EmboShield that we keep proximally in the ICA. So here we can see, I think this is an old cath lab we did. Someone is see the umbrella-like device here. It's tough to see here. The umbrella-like device, and we have kept the embolic protection device initially. Then we went to the lesion, and we are doing that angioplasty here. And you can see in the first image deploying the stent inside across the lesion, and we deployed that carotid stent here. And post angioplasty, you can see the filter here. I kept the tarot. I think it's difficult. I will show in the next patient. So here we are doing the post stent angioplasty. So post stent angioplasty, and you can see there is no occlusion here. The flow has been restored. So this is a procedure where we are deploying thing. If you are interested, I will run it, or if you are running off time, I will run across this. The second case is 70-year-old male, hypertension, left MCA territory in the February 24, and in March 24 he had recurrent stroke on the same territory. The last 10 days, once in 2 days he is getting a TIA. So he is on double antiplatelets, ecospirin, ticagrelor, and CV Doppler showed left ICA 90% stenosis, and his cardiac workup was normal. So there we can see here the 90% critical tight stenosis here. So we are passing our O10 wire, micro wire here. So we can see that embolic protection device here clearly. This umbrella kind of thing which is here. So this is an embolic protection device we have deployed. I can see, and we have passed it through the lesions and did pre-angioplasty, and we are deploying the stent. I'll run quickly how we are doing. So this is the wire going across the ICA. I think in sorry. Fast forward stands marker. That's okay.
Fast forward sir. PPT కదా.
అవుదా?
యారో మార్క్ చేసింది.
ఎలాగా?
యారో క్లిక్ చేసింది సార్. ఫాస్ట్ ఫార్వర్డ్ అవసరం.
అవుదా? I think it's a 1-minute video. I'll run later. So conclusion, EVT has improved greatly to treat disabling and severe strokes, and one should be able to assess NHS while handling stroke patients, and one should pick up LVO, transfer to stroke ready centers. LVO treated with mechanical thrombectomy, outcomes are good, and eligible patients can be offered EVT up to 24 hours. So these are the few stent retrievers. Now the scope of intervention in neurology is digital subtraction angiography, mechanical thrombectomy, carotid artery stenting, and SDH embolization. The role is recurrent when we see the elderly patients on double antiplatelets and statin had a recurrent falls developing recurrent SDH. So embolizing the middle meningeal artery will reduce the recurrence, and we can also continue the antiplatelets and aneurysm coiling and management, intracranial stenting, and all these procedures we have done. And once the time permits, we will discuss on second part when we get a opportunity. And this is a digital subtraction angiography which provides an imaging of blood vessels in the brain and detects a problem in the blood flow. So indications I have already mentioned. The therapeutic and diagnostics. So this is the thing someone was mentioning about the AV malformations. This is our new cath lab we got recently with good visual clarity. You can see that brain AV malformations there. And this is from left IC injection where the embolization getting filled, and we have done embolization, transvenous embolizations. I will be presenting in the subsequent videos. So someone was asking about the flow diverter. This is a thick flow diverter. You see the giant aneurysm in the ICA. So what initially we have deployed a flow diverter here. You can see the micro catheters are inside the aneurysm. We diverted the flow and we coiled the aneurysm. That's all. So you can see the post shoot that there is a flow diversion without filling of aneurysm, and the coils are inside the aneurysm. Thank you for the given opportunity. This is a World Stroke Day. Minutes can save life, which is celebrated on October 29th. And I thank Pitapuram IMA team and Balaji sir and Sridhar sir who encouraged me to present these topics and who always discusses about all the stroke cases frequently. And also thank to the Pitapuram IMA team and giving me this golden opportunity to present my small work, and also the Medicor team who supported me for giving a new cath lab for us, which is compatible with interventional procedures. And yes, hope we will pick up this branch soon in with affordable sector and in affordable prices. Thank you. Thank you.
Thank you, sir, for such an enlightening presentation. Any questions from the audience?
I think we differentiate ourselves.
Sir, TA is a transient ischemic attack, sir. Resolves within 24 hours topic unde, sir. It's 1 hour without any defect on MRI, sir. Any neuroimaging. Transient ischemic attacks.
As we are staying in rural area, which one is stroke for CT or MRI?
Sir, CT.
CT.
Sir, there is nothing that you should do MRI. There is nothing rule that you should do MRI only, sir. Most of the trials are with CT angio, sir. Because what we is only CT, simple CT is enough, sir. Suppose if the patient is TIA, we take a CT, defects clinically improved, it's TIA. If there is a right-sided weakness, mild facial peripheral, CT there is no bleed, small hypodensity. The disadvantage is CT will take at least 6 hours to pick up a hypodensity. The diffusion pickups much more. So when there is a measurable clinical deficit, CT there is no bleed, yes, he is a candidate for IV thrombolysis.
In our daily practice, we are seeing in CTs small ischemic vessel diseases that
Yes, sir.
What to do in that situation?
Sir, small ischemic. Correct, sir. Yes, sir. These are things. The small vessel ischemic diseases are with that lenticular striate branches, very small vessels, because of hypertension, sir. Lots of research has been studied whether the small vessel disease increase the risk of stroke or it increases the bleed. Mostly with small vessel disease, it's in the periventricular area. The gait will be affected. Usually, we offer no intervention for small vessel disease. Only thing we control the risk factors, hypertension particularly.
Thank you.
Sure, sir. Sure, sir.
The stents are self-expandable or?
Sir?
The stents, no?
The stents are self-expandable, sir. Self-expandable. We have different stents, non-expandable, self-expandable. So it will expand, so they are self-expandable. We do post-stent angioplasty also, sir. What we are doing is exact company about one self-expandable. We also have different stents.
The thing is that the thrombus protection device is compulsory or?
Sir, they recommend to use EPD, sir. But however, because of cost constraints, without EPD also we are going stents, sir.
Okay.
Without EPD also we are doing stents. But it's only thing, once the question comes when the stroke happens, you should have used it. That is a question frequently any person can ask. So we do counsel with embolic protection device. So most of them, actually till now we have kept 5 stents, sir. With all 5 we have used embolic protection device. Only one patient who cannot afford EPD, we have put I have taken a calculated risk and taken it. But yeah, it went well.
What is the cost of this?
Because the stent material with pure stent is around 65,000, sir, from the company. Any stent, there are 5 companies, sir. Boston Carotid Stent, Exact Stent, and these things requires the use of EPD. So EPD and together comes around 1.5 lakhs, sir. Now recently we are getting this new stent, sir. I remember this is a closed stent, sir, open closed mesh stent. We are getting a C-gut stent particularly. So it says that it can prevent, when we are putting a stent, when we are doing angioplasty, the small material 2 micron, 3 micron sizes can go and up and cause a stroke. With the exact stent, it has a protected mesh around it to prevent the distal embolization. So now it has been started in many centers. They say that without EPD we can do it, but always some recommend always keep some protection distally, because when major stroke happens, the question comes, why I have not used it. That's the thing. Other thing.
Easily retrievable, but
Yes, sir, that's retrievable, sir. We have to carefully retrievable.
Good evening,
I think
everyone.
I have that video.
It is our privilege to-
Permits, I will play in the time. Sorry, that's the sir.
actually, is it possible to go to the cath lab without this CT and clinical? For
Sir.
example, in my cases,
Sir,
I started ECG. is
Sir, using, sir, there are few scenarios where during my training where CABG patients, where not CABG, sorry, when cardiac stent, immediately stent was done to LMCX, or then suddenly patient got collapsed and developed seizure on table. Such cases, we have few cath labs are equipped with CT itself, sir.
Okay.
Vaso CT we call. I think you might be aware of that. Vaso CT, we take a Vaso CT, then we take a DSA, we take it without any imaging, sir. It will hardly take 9 to 10 minutes, depending upon the experience of the person who takes. So we do CT angio, because CT angio is essential, because as a cardiologist navigating the circulation system, we have to know the arch of the aorta. Suppose if a type 3 or Bowen arch, we can't go for conventional, we have to change the Kettering road mapping. Planning is totally different. So we do from CT angio arch of aorta to circle of Willis, sir.
How many cases you are being frequently?
Sir, monthly hardly one, sometimes 1 month, 2 months and once we are doing. But yeah, we are outside, we are going, sir, with our friends, like that we are getting things. Because the only thing is cost effective, cost around 3, material itself is around 2.5 to 3 lakhs when we use N material. So I think it's only the cost factor that is, because stent retriever itself is 2.4 lakhs. So when we are using stent retriever, the cost comes around 5 to 6 lakhs. So at present we are only attempting aspirations, or only affordable sectors incidence reimbursement is there, we are expanding and doing stent retrievers.
Really, it's a very excellent work.
Thank you, sir.
Because, this work is available in Kannada, really, that's good.
Yes, sir.
Great work.
Thank you, sir. Thank you, sir. Thank you, sir.
So we'll move to our next speaker. A small AV for our next speaker, Dr. Krishna.
Good evening, everyone.
Good evening, everyone.
Dr. Pilla Sridhar, a dedicated intern.
Sir, 5 minutes and I'll get time. Sir, ఈ లోపల ఒక చిన్న డిస్కషన్ లాస్ట్ టైం అడుగుదాం అనుకున్నాము. సో బేసికలీ ఎమ్ఎల్సీ కేసు మనకు వస్తాయి కదా. సో షుడ్ బి చార్జ్ సమ్ డాక్యుమెంటేషన్ ఫీ ఎమ్ఎల్సీ కేసెస్ మన దగ్గర వచ్చినాం, బికాస్ వేరియస్ సెంటర్స్లో వేరియస్ ఛార్జెస్ ఉన్నాయి. సో మనం యూనిఫామ్గా ఒక ఛార్జ్ ఏదైనా అనుకుని ఇఫ్ ఎవ్రీ వన్ చార్జెస్ ద సేమ్ థింగ్, అయితే there will be no discrepancies with respect to patient. Any thoughts about this?
Regarding bills per se,
Sir, డాక్యుమెంటేషన్ మెయింటెనెన్స్ ఛార్జెస్ అని పెట్టాను సార్. ఎమ్ఎల్సీ కేస్ షీట్స్ మాకు ట్రామా అంటే 14-15 years అలా ఉండాలి. దాని టైం లిమిట్ అంటూ ఏం లేదు. సో యూజువల్గా వాటిని డాక్యుమెంటేషన్ మెయింటెనెన్స్ కోసం మనం థర్డ్ పార్టీకి ఇస్తే దే చార్జెస్ ఇయర్లీ బేస్. సో ఆన్ దట్ గ్రౌండ్ ఇంకోటి ఏంటంటే, మనం ఎప్పుడైనా ఎమ్ఎల్సీ కేసుకి వెళ్ళినప్పుడు దే ఆర్ యాక్చువల్లీ సపోజ్ టు పే అస్ ఫర్ ది విజిటింగ్ ఫీ, బట్ దే డోంట్ పే అండ్ వీ యూజువల్లీ డోంట్ ఆస్క్ ది అడ్వకేట్స్ అది పీపీస్ అడ్వర్టైజ్మెంట్. సో దట్ ఆల్ సమ్ యూజువల్లీ ఆల్ ద హాస్పిటల్స్ Yes, sir. ఎందుకంటే ఐ ఆమ్ ఛార్జింగ్ ఫర్ దట్ బట్ ఒక్కొక్క ఏరియాలో ఒక్కొక్కలాగా ఉంది. సో ఐ గాట్ రీసెంట్గా ఒక ఇన్సిడెంట్ జరిగింది. మన అడ్వకేట్ కాల్డ్ మీ. ఐ షుడ్ గో అండ్ ఆస్క్ ఎనీబడి ప్రాపర్ అథారిటీని అడిగి ఎంత ఛార్జీలో చెప్పిన అంతే ఛార్జ్ చేస్తాను. అది మనం ఒక అమౌంట్ ఏదైనా అనుకున్నాము అంటే సార్ వేరియస్ సెంటర్స్ డిపెండింగ్ ఆన్ సెంటర్ 2000 to 5000 ఉంది సార్. అది వేరియబుల్, దేర్ ఇస్ నో ఫిక్స్డ్ లిమిట్ యాక్చువల్లీ. అందుకు
సో నెక్స్ట్ వీక్లో మన కాశీ ఉన్నారు దాంట్లో మనం దీన్ని మనసులో పెట్టి నెక్స్ట్ వీక్ టేక్ డెసిషన్. ఓకే
సార్,
నెక్స్ట్ వీక్.
Everyone. It is our privilege to introduce our esteemed speaker, Dr. Pilla Sridhar, a dedicated internal medicine specialist and general physician based in Pithampur. Dr. Sridhar brings over 6 years of clinical experience and serves the community in his practice at Sri Krishna Multi-Speciality Hospital located in Pithampur. Dr. Sridhar's academic journey is a testament to his commitment to excellence in medicine. He completed his MBBS from the prestigious Andhra Medical College under Dr. NTR University of Health Sciences, Vijayawada. He then pursued his DMD in General Medicine from the National Board of Examinations, enhancing his expertise in managing complex medical conditions with precision and compassion. Beyond his medical profession, Dr. Pilla Sridhar is also a politically active individual and a committed social worker. Over the years, he has been at the forefront of initiatives aimed at the progress and welfare of the people of Pithampur, from supporting families in their most difficult times, championing developmental projects that uplift the local community. His unwavering dedication and involvement, his unwavering trust and respect, shaping him into a genuine who stands for their needs and aspirations. Dr. Sridhar's unique blend of medical expertise, social commitment, and grassroots leadership embodies the very spirit of service we celebrate today. He will present a case report on the cerebral venous sinus thrombosis, secondary polycythemia, and hyperhomocystinemia, sharing insights drawn from both his rich clinical experience and his deep understanding of the community he serves. Please join us in warmly welcoming Dr. Pilla Sridhar to the stage.
Of this patient, and we will reduce the morbidity and mortality. Coming to the case, he is a 25-year-old male. Kadari is from our near village Chebro. Weakness and of since on the examination, his vitals are fairly stable. BP is 140, 60 per mild right systems are normal. At the level as bilateral transfer signs appear to be hypotenuse, and they also commented that a small area of hypotenuse in the left high frontoparietal region. So with this cerebral venous thrombosis was we have sought and admitted the patient into ICU and started with anticoagulation and supportive care. Next day, MRI brain with MR venous. So with this cerebral venous sinus thrombosis diagnosis for the cause of the cerebral venous thrombosis. This is the basic investigation. His thrombotic condition and polycythemia, whether it is primary or like polycythemia vera or any secondary cause for the polycythemia. Other investigations were fairly normal, LFTs are normal, and even coagulation profile also, basic coagulation profile also. Along with the treatment routine in evaluation, that JAK2 mutation was sent, it came as negative. So that primary polycythemia was excluded, and for the secondary causes and stroke in young patient elevation was there. So with this diagnosis of secondary polycythemia vera and hyperhomocystinemia, it caused so along with the management, now the even exactly secondary polycythemia diagnosis was made, but the cause is still not yet identified. Serial monitoring of the hematocrit and hemoglobin was made, and even with the good hydration, no much improvement in the hematocrit. So then we sent for what is the cause for his polycythemia. So this patient outcome was very worse. He improved and there is no recurrence of symptoms. He is under my follow-up till now. So coming to the discussion, cerebral venous sinus thrombosis in young adult was it warrants evaluation of the thrombosis and hypertension. Both have a high risk of thrombosis. Is the so with this case ends, but again here we don't know the cause for the polycythemia, why he got 21 hemoglobin. We started asking the history. So again we'll ask whether you have smoking, tell me any other things are there, means he was not having any smoking anything. Then where you are working in the temple? Actually he is working inside the temple. I think many of you know that the Satamdali temple, it is a very close small temple where he used to give harati and everything. The lot of smoke and a lot of hypoxia was there. Usually for the secondary polycythemia, usually hypoxia is one of the reason, and renal cell carcinomas where erythropoietin levels increase and it will cause the polycythemia. Smokers, exposing to suffocation. Then he developed the polycythemia. Then we advised him to came out of the temple and work outside the temple. Later, his hemoglobin was maintained around 16 to 17, but he is symptomatically very better. He is in undergoing follow-up. Thank you. So usually, why I presented this case is because regarding the evaluation, we used to do a lot of investigation, lot of evaluation, everything we used to do. My boss is a gastroenterologist. He used to tell that you young people always depends on the evaluation by investigating, but we are the old people, we always believe the history. History will give the 90% of the diagnosis, he used to tell us. So this is one interesting case I have gone across. Thank you very much for this opportunity.
Thank you, sir. Any questions from the floor? So we move with our next section, that is felicitating our guest speaker. I request Dr. P. and sir, Madam, sir, Salman sir, please come over for felicitating our guest speaker, Dr. Krishna Haskar.
Sir, my violin is audible. To increase the volume, or is it okay, sir? Yeah. Yeah, yeah, ma'am, I can hear you, ma'am.